think Dr. Gagan wants to present the next topic, and then we can have the discussion together for both the topics. So I now invite Dr. Gagan Bhatia. He'll be talking to us on bimanual surgery, the savior.
So maybe you can come on the dais, join us on the dais so that.
Come. Come, Sangeet.
So after Dr. Sangeet's very lucid description of Unimanual, I think I need to kind of challenge this the bimanual way. So I think going back to what Dr. Darius had spoken about, studying these cases and understanding vitreous cases and why it is important to understand this, this phenomena is because to find the right plane of dissection. This basically helps us to first is get the right plane. I think there are adjuvants which I think Dr. Sangeet was also asking about, which have been used. But I think if you have a preoperative OCT wherever possible, I think then finding the plane becomes much easier. And I believe that initially getting into the right plane of dissection kind of makes the case very easier and really helps us in preventing any iatrogenic collateral damage. I think preoperative anti-VEGF is what we all know, and I think Dr. Sangeet has also spoken about it. So coming to why bimanual surgery, I think one is that it gives you very precise way of knowing or identification of a tissue plane, especially in places where you have not preoperatively studied the case. I think there is very precise detection and cutting of the vascular connection. So as we know that in PDR, it is more the vascular nails which need to be kind of separated, and that makes this bimanual makes it very easy and controlled. I think there is a way of coagulating the bleeders that I'll show bimanually, and also it ensures complete removal of the fibrovascular tissue and traction, though I think Dr. Sangeet has also described it his way in a very perfect way. And second thing, what I always feel is that in a bimanual hand, I think one hand kind of supports the other hand, so you don't have undue tractional, excessive traction going the contralateral way in this. So in this case, this is basically a normal PDR vitrectomy. So in this, as Dr. Darius had shown, this is the same case which he was showing, in which he was inducing getting into the posterior hyaloid. So we thought that we'll continue with the bimanual dissection here. If you see, we have been able to kind of enter into the right plane of dissection bimanually, and dissect the membrane into smaller leaves, and then bimanually take care of the membrane. If you see one hand, you have a very controlled way of holding it, and then you can interchange between cutter, scissor, forceps, and there is no underlying, probably not causing much underlying traction on the retina, or if you would have done it the unimanual way. So in this case, this was a one-eyed lady and her retina was on, and I think the challenge was not to use any tamponade, etc. So there was a bleed over here. So so this is where you have a bleed, and the cutter kind of helps to kind of keep clearing the field. So you basically were using a cutter and a scissor. So the cutter kind of controls the bleed, clears the field, and then you could use probably a flute needle and a endothermy to cauterize the bleed. So this is a bimanual way of cauterizing the bleed at that time. And then you can take care of the membranes. And this is the last membrane which was there in this case. So I think a very controlled way, you can interchange between scissors, forceps, scissors. Then coming to this case, which I think Dr. Sangeet had said that very thin retina. So this is a case of very thin retina. Again, if you see in the bimanual way, you can get into the correct plane of dissection. In many a times, the heme kind of helps you to find the correct plane, because if you kind of just cleave it back, you could see. In this case, the retina seems to be extremely thin and very chytic. So any undue force on this retina would lead to an iatrogenic break for sure. So I think, at least in my hands, I think bimanual way would be the better way. I don't know if, we'll see in the discussion if really Dr. Sangeet would go ahead with the unimanual way in this case. And so you still see that little bit of sheen peripherally, but there is, so I think you can probably get into the right plane again over there, and we'll handle that one membrane peripherally and go out to from in to out. And then finally getting into this plane. I think so if you see, all these vascular nails can be attacked very carefully over here, and then with a close scissor tip, you can probably create your plane of dissection and kind of clear all those vascular nails and carry on with the dissection. So this is one step where I feel, and this could be a part of the discussion, is where you see there are these very, very tight connections around the disc. So at least what I personally feel is that like if you see all those dissections around the disc, I don't know how it would behave if I would just pull them the unimanual way and block. I think that is something that we need to learn from Dr. Sangeet, and it also takes us to a very, it would take us to a very good dissection. So I would also be waiting for his comments on this, because usually we would have this kind of this thing. So let's come to the next case first. So and then this case was completed. Then we have cases like this where you have a membrane with no edge, because the membrane and the retina is all one. So I think you kind of enter into the posterior hyaloid wherever you can, and then obviously with the help of depression, as Dr. Darius had also shown initially, to find the right plane. And the idea is basically to separate the membrane from the anterior extensions. Sometimes these anterior extensions are till the ora, and in this case it is till the ora. So we kind of lift up this membrane, and with the help of depression on one side, kind of try and separate the membrane all around, and do the same procedure all around 360 degrees. This nasal edge was extremely stuck, and there was no way that this was coming off. Didn't want to make an iatrogenic tear. Now this is one step which I want to again could be a very interesting point. If you see that thick layer, seems like that's the area of entry, but if you actually see the area of entry is that very thin whitish membrane which is there. I don't know, at least in my hands, I would never be able to get in the unimanual way. I think bimanual gives you that plane of dissection. Kind of very carefully you enter, and then finding the a vertical clear edge, kind of dissect the membrane into two halves. Again, these vascular nails are extremely tight. So what I personally feel is, if you create kind of a plane of separation around them, hold the membrane with one hand very steadily, and then kind of tackle each and every nail as you go along. And then again separating the all the vascular connection in that area, and tackling this leaf of the membrane is tackled. If you see till the periphery, the attachments are very, very tight. So you could probably find little planes where you can get in and cut them into smaller leaves, but then again I think a complete dissection would need a bimanual surgery. So, and again, if you see over here, the attachments are again very tight. Both the two poles are kind of separated first before the membrane is lifted up, so as to prevent iatrogenic breaks at the edges of the membrane. So we tackle this leaf also the same way. Now we're coming to the first nasal edge. So the nasal edge was extremely tight, and when we were taking care of the nasal edge, I kind of realized that there's a big round mass posterior subretinally. So I think going ahead with very, very aggressive dissection at this point, because I was thinking that it's imperative that we take off of all the fibrous tissue and the vitreous, and probably have a break over there, a retinectomy over there to tackle the subretinal membrane. So this was again taken care of bimanually, and then we kind of took this subretinal hemorrhage mass out. So like a big monster. So this is a bimanual way again of taking out hand-on-hand technique, and then finally the case was settled, and tamponade was used.
Very good.
So I think to summarize, I think we go back to the principles of PDR surgery. I think we've covered the two techniques and we have covered the preoperative assessment. I think understanding vitroschisis is very important. I would say yes, cut a scissor, forceps scissors, and I usually go with the outside to in approach. Uh, One point is that it helps you find the plane of dissection, which is again debatable from the unimanual point of view, but at least I feel that once you have separated the anterior surface, you do a good base excision, then even the in and out of the instruments and everything, I think you would probably not cause any undue traction on the peripheral base. And I think very controlled handling is important, and patience and persistence always pays. Thank you. Sir, I think you should come on a time. Second video. You want, yeah.
I think
Can
that
I have my slides back, please? These slides back.
really very excellent, very well done. Of course, there is no hard and fast rule whether you should do only unimanual or only bimanual. You know, during surgery, you may have to change strategies and, you know, from unimanual to bimanual or whatever is comfortable and whatever is safe for the patient that you need to do. So, Sangeet's technique is also very good, but I just have one small criticism for that. Is that, like Gagan also mentioned, that often there is a dense adhesions around the disc and a little bit outside the disc, maybe not exactly at the disc, but in your video also you saw that there were some adhesions right next to the disc. Now the technique that you are doing is pulling it from the disc. I personally believe that now at this stage of your experience, you know how much to pull and up to what extent to pull and where to leave it, okay? But there are novice people and young people, they really do not know when to leave the traction. And if a new person is doing and a junior person is doing, I am sure they will end up with peripapillary breaks. Because in my own experience, when I was younger, when I was doing this center to periphery dissection, I myself have created breaks like that. So that is one thing I would like to maybe caution the young people. What is your take on that?
Yeah, first of all, I'm not demonizing bimanual surgery. I myself do it very frequently, right? Though my way of doing it is totally different, but I do it very frequently bimanual. Yeah, you are right in many cases, like where we have very tight adhesions near the disc or in which there is very thin retina and sometimes the disc is not visible. It's so dense membranes are there. You have to start from the periphery and do a bimanual dissection. In those cases, I generally prefer to do a bimanual dissection. And when I do a bimanual dissection, I generally make cut from the periphery and make all around. I prefer to go 360 degree as you showed, and then start dissection. For the unimanual thing, when how much to pull for beginners, I would advise is like if you feel that you can pull, just try once, and just leave it. As soon as the membrane separates from the disc, just leave it, right? And if you're not able to do it for the first time or the second time, just leave it, do the other way, right? In the beginning, I will just advise this. But most of the time, as I said, it is not difficult. It doesn't bleed, it doesn't cause tears. And the dissection in almost 90% of cases becomes very, very easy.
So actually, coming to even cases like these, I would never attempt what you do, and rather the case that you also showed, I would never been able to attempt what you did. So I think that's really, really brave of what you do. I just wanted to know one thing, that if you have a bleed, so my biggest fear is, okay, you lift it up, fine, you probably, in the beginning, okay, you might not get into the right plane or you don't lift it completely. But and if you end up with a large bleed, so one of the problems that in diabetic surgery is that one is that you increase the bottle height to stop the bleed. Sometimes the bleed doesn't stop, so these problems do happen. But then, how do you clear that bleed? Because you have the membrane still there, and you have the bleed also over there. So then that is basically making like a multi-layer vitroschisis. Now, because you have a layer of membrane, then you have a layer of bleed, and then you don't know where the retina is. So then how do you go and clear that bleed from there?
In case sometimes
you
do encounter, even if you're doing the other way around, you can have these kind of bleeds like over the retina and becomes very messy over there. But what I advise is as soon as you lift the membrane, and if you see that the disc starts bleeding or even if a small ooze starts happening, just increase the bottle height, stop there. Stop for 3 minutes, right? And it will stop there only. It won't increase much. And definitely if those kind of bleedings happen, every surgery becomes a mess.
Sangeet, what setting did you use? Because I think we are always worried that in detached thin retina, we are scared of using the cutter because of breaks, but you showed so beautifully that you are using only the cutter. So what are your settings and system which you are using?
I generally use the 10,000 cut rate.
Okay.
And 650 vacuum. I just control with the foot.
With the foot switch,
yeah.
okay. And you go in the shave mode for in constellation.
No, I use the core mode only.
So even in case,
even if my shave mode is there, I just decrease the vacuum, but a little bit, and the core, the cut rate remains the same.
But that's full control, because if we are trying to give a message to beginners, we'll tell them put the suction very low, because by mistake also if it goes up and you have detached retina, you can get a break. And
Yes,
second thing,
see, one thing is like if you keep your suction low, you won't be able to perform this type of dissection.
okay,
If you keep your suction high, the membranes itself, they will start coming into your cutter. And if they are not coming, it means that there is a second membrane below it.
then you have to go low.
And then you have to explore with your forceps and see whether there is some membrane around that particular epicenter or not. And then you can just peel it off.
no, but even in cases like the combined detachment that you showed, so you go with the same settings, because
Yeah,
we
same
usually
settings.
have that
No,
feel that
same
kind of
settings, same settings.
settings.
See, if you keep it low, it won't be successful. Then you'll have
Nowadays
problems.
with this MIBS, the retina remains stable. It does not jump so much. But it is very important that how the port is directed. So port should be definitely directed away from the retina, and then you can use those, what are those techniques described where you keep the
roll
cutter,
back.
fold back technique and all those, so that the membrane gets cut and the retina is spared. And also now there is a gap between the port and the cutter tip, and it is also a bevel tip, so it can go easily in between the retina and the membrane. So some amount of retinal safety is there, unlike the 20 gauge cutter which were so difficult.
I had one more video, but because of the time, I could not show it. In that video, we had discussed all these things.
Dr. Sangeet, Dr. Gagan, great surgeries first. I am a lot of believer in what Dr. Sangeet does. I would have mostly tackled disc very often than not, and I generally start from disc. Few tips which I said, as Dr. Dhanashri was saying, if my fellow is doing, I don't let them touch the disc. The step of pulling the disc, I'll come, lift it up and give it to them. Because when they're more tentative on the disc and they just try to tease on the disc, they tend to cause more bleeds, and those bleeds happening within the interfaces. I'm sure most of us who start off with disc, we have one firm grasp at the disc, just lift it and leave it. And we are able to assess that plane has come off, the hyaloid just comes off, and then you can shift to your cutter. And secondly, if it starts to bleed, don't do anything. Just a masterly inactivity for a couple of minutes just stops the bleed. Very rarely have I encountered a situation where I have actually been in that big a mess with the disc. I will not touch a disc which is looking visibly vascular. Like this particular disc does not look that vascular. I would have probably started off at the disc. If it's looking too vascular, then one can avoid touching.
One more thing I would like to say, when I started doing this technique, we were using 20 gauge systems at that time, right? And at that time, what I used to do initially was make a small hole just near the disc to access the disc properly, to hold the membranes properly. And I had at that time designed a forceps which was just like your vertical scissors. It was not a scissor but a forceps. So just go in, hold it from there and just pull it off a little bit and it would come off. So now because of the smaller gauge, I'm not using that particular instrument, but it can also be.
Another thing, intraoperative OCT again helps here. On intraoperative OCT, one can actually find the plane where the hyaloid is already slightly lifted off the disc, and you go in that region and just pull it off, it comes off easier just to act to.
Right.